Welcome everyone to Fits on the Go. We're covering ACC 2024 live from Atlanta, Georgia. My name is Conor Lane and I'm a cardiology fellow at Mayo Clinic, Rochester. And I have the distinct pleasure of being joined by Dr. Michael Gibson. Dr. Gibson is a professor of medicine at Harvard Medical School. He is an interventional cardiologist at Beth Israel and leads the BAME and Perfuse Research Institutes and has led many clinical trials. Today we're talking about the AEGIS-II Trial, which was presented as a late-breaking clinical trial yesterday here at ACC 2024. Dr. Gibson, thank you so much for joining us.
Great, thanks for having me.
I'd first like to congratulate you on this very impactful trial. I was hoping you could first maybe explain a little bit about apolipoprotein A1, its role in HDL and cholesterol efflux, and the rationale for AEGIS-II.
Well, we've all known for years that the lower the HDL, the worse the outcomes. So the natural question would be, what if we raise people's HDLs? There were many attempts to do that. They fell short of improving outcomes. We think that was because there was off-target toxicity. Some of the drugs raised blood pressure or CRP. And the other thing is if they raised good cholesterol, it may not have been as good as we thought. It may have just been okay cholesterol, I like to say. So how do we know if someone has really, really good cholesterol? We measure it called cholesterol efflux, and we put some radioactive macrophages that have lipids that are radioactive there, put the patient's blood in with it, and we see how good is the patient's blood in getting the cholesterol out of the macrophage. If you can get it out of the macrophage, that's good efflux. There's a tendency to want to give drugs, but we didn't want off-target toxicity, so we gave human ApoA1. ApoA1 is the building block of HDL. So think of it as empty garbage trucks. Empty garbage trucks with a much better trash compactor because it's modified in a slightly to make LCAT better. This is the thing that shoves the cholesterol into the middle of the particle. So we know that people with 6-year mortality have worse efflux. We know this drug improves efflux. So then we did a study to say, can we improve outcomes? We randomized 18,200 people, half to the CSL 112 compound, half to placebo. The placebo was matching in color and consistency. They got 4 infusions spaced a week apart. These were high-risk patients who had multivessel disease. And we didn't see any difference in death of my stroke at 90 days, but the curves continued to separate over time. And by 180 days, we saw a trend, a P of 0.077. But when you look at MI, we reduced MI. When you look at death in MI, we reduced that. And very importantly, and the only subgroup that we really looked at, reported on, if you have an LDL above 100, there is a 36% relative risk reduction and a 2% absolute risk reduction in death and MI. The interaction p-value there was positive, meaning that this subgroup modulated the treatment effect. So it kind of makes sense, right? If you don't have much garbage in your bloodstream, you don't need garbage trucks. But on the other hand, if you are hyperlipidemic and probably have some plaque, then maybe this therapy would be of benefit. So I think as a group, we felt that the hypothesis was supported that HDL has a role. But I think we need to pivot away from calling it the HDL hypothesis. I think we can now call it the HDL efflux hypothesis. We're not just trying to raise the number of HDL particles. We want to improve the function of those HDL particles.
And did you notice anything from a safety endpoint perspective between the two groups?
There were 14 hypersensitivity events in the CSL arm. Of course, it's a human compound, so you may have some hypersensitivity. There were 4 in the placebo arm, so yes, there were more. But on the other hand, acute kidney injury was improved by about 6.7%, so it goes both directions.
And there was some interesting data on stent thrombosis as well. Is there an explanation for that?
Yeah, I got to be honest. You ask an honest question, you get odd answers. And it was fascinating because the stent thrombosis reduction was early. It was like in the first days during the infusion. It's not like, it emerged late or something. Right during the time of the infusion. So ApoA1 does have some antiplatelet effects. It may have stabilized the plaque underneath the stent and made it less thrombogenic. We're not quite sure, but it was a very, very robust signal.
And so, what do you see as the future for CSL112 or apolipoprotein A1 future trial directions, or when do you think is it ready for clinical time yet, or do we need more research into its effects?
Yeah, I mean, you got to understand this information's really hot off the press, just a month since we got the data, so we haven't really had time to really explore. So we need to look at the who, what, when, where, why, how of everything that happened. Then we'll start charting a course. For all of you who are working in this space, I do think that this is a viable target for anyone who wants to explore it. So the cholesterol efflux hypothesis, I think, is alive and well.
Well, certainly very interesting results, and I'm sure it's not the last we've heard of ApoA1. Thank you, Dr. Gibson, for joining us. To watch more videos like this, please check out youtube.com/FITsOnTheGo and follow us on X @FITsOnTheGo.